Welcome back. Let's continue with the new topic of bronchiolitis. In bronchiolitis, you need to know what is this condition. Is it lower or upper? Obviously, it's an acute lower respiratory tract infection, more commonly seen in infants, usually occurring in winter or spring. So, the affected age is also early or the first half of infancy, means usually the age group of 1 to 6 months. Okay. But sometimes cases up to 2 years of age can be seen sometimes in the wards. The most common agent is your RSV, respiratory syncytial virus, and otherwise there can be other viruses, influenza, parainfluenza, adenovirus, and sometimes mycoplasma also. So protection against RSV is mediated by the antibodies of Ig3, okay, Ig3, IgG3, subclass antibodies, and these antibodies actually have a short half-life and do not cross the placenta. Then secretory Ig antibodies to RSV are also present in the colostrum. So breastfeeding therefore reduces the risk of an infant being hospitalized with bronchiolitis. So what are the protective factors? It is breastfeeding, because in that we get the IgA antibodies, secretory antibody, and apart from that the specific antibody to provide protection is IgG3 subclass. Now, what about the pathogenesis? Inflammation of the bronchiolar mucosa. So, you have the bronchioles, the mucosa will get inflamed, there will be edema and bronchiolar spasm. The wall will undergo spasm, narrowing, and the mucosa will also be edematous, so there will be some fluid buildup. There will be thickening of the wall, and also, as we discussed at first, there will be edema, and later on in the lumen, there will be formation of mucus plugs and cellular debris. Mucus plugs and cellular debris also. Then we know that airway resistance is inversely proportional to the fourth power of radius. That means the airway resistance is inversely proportional to the radius raised to power 4. That means even when there is a mild narrowing, means the radius decreases little bit, there will be a marked increase in the resistance, and so the airflow will be markedly reduced. Right, so resistance to airflow is increased both during inspiration and expiration, but more so in expiration. The resistance is more in expiration, because we know during expiration it's more difficult. Cause in inspiration the air comes in with a negative pressure, but expiration it's more difficult for the air to escape. Then this leads to trapping of air inside the alveoli that causes emphysema. And later on may result in atelectasis. Decreased ventilation and diffusion in severe conditions leads to hypoxemia and respiratory acidosis. Okay. So, what will be the clinical features? So, what do you think are the clinical features? It begins as an upper respiratory infection. After a few days, the child has high fever with rapid breathing and respiratory distress. So, that is fever, rapid breathing, and respiratory distress. Those with severe disease show the retraction of the lower intercostal spaces and also the suprasternal notch. In severe infection, infants have respiratory distress and are cyanosed. So, in severe cases, there will be these retractions, respiratory distress, cyanosis. Expiration is prolonged. Why? Because it is difficult to expel the air, because a lot of resistance is being faced by the air which is leaving the airway. So, expiration is prolonged. Use your common sense. When expiration is prolonged, the breathing will shift its pattern, because in a vesicular breathing, inspiration is longer and expiration is short, but here expiration is getting prolonged, so you will start to get something like a bronchial pattern. Then sometimes other breath sounds such as fine crepitations, fine creps, okay, fine creps and rhonchi. Now there is a very logical explanation. When will you get coarse crepitation and when you will get fine? In coarse crepitations usually you get when there is more of exudates. So whenever there is condition which is having exudative type of problem, for example pneumonia, TB, in these cases when you get creps you will get because of exudate, a lot of pus is there and you get coarse crackles. But if there is a condition, say congestive heart failure or some heart problem, because of which there is a backward flow of blood into the lungs, and in lungs then the fluid that is present is transudate, and transudate it's having a lower viscosity, lower specific gravity, also the character of the crackles are fine. So whenever intrinsically there is more of exudative type of fluid accumulation, that will cause coarse crackles, and when there is transudate that will cause fine crackles or fine crepts. So here in bronchiolitis There is not any abscess formation, there is not any pus, so there will be fine creps. Apart from that, the breathing will be going towards the bronchial breathing pattern because expiration is prolonged, and sometimes bronchi are also seen, not seen, heard on auscultation. The breath sounds are faint. That means there is decreased air entry. Air entry is decreased, so the breath sounds are diminished or inaudible in severe cases. Then air is also getting trapped because we talked about expiration is becoming very strenuous. The air is not able to go because the resistance is increasing so much more. Okay, it is increasing 4 times, and because of that, the air trapping occurs in the long run, and because of that, the liver and spleen, they are pushed down. So you also, when you will do the percussion, you will see the dull note of the liver will not be seen in the fourth intercostal space, it will be seen below that. Okay, so liver and spleen are pushed downwards, and anterior posterior diameter of the chest is increased, just like emphysema, a barrel shaped chest, because air trapping is occurring. So in severe cases over a long time, we will see the child will show an increased AP diameter of the chest, and there will be hyperresonance on percussion. So on percussion there will be hyperresonance. So what are all the clinical findings? When you will see inspection, on inspection you will see a barrel shaped chest. Okay, anterior posterior diameter will be more than transverse diameter. That may be appreciated if it is marked. Apart from that, you can see the retractions in the intercostal spaces, especially lower intercostal spaces and suprasternal notch. In that area you might see retractions. The general condition of the child will be deteriorating. He will be in a state of dyspnea, tachypnea, respiratory distress. He may be cyanosed. Okay. Then, when you will try to do the palpation, you will check out for these findings. You further exactly measure the AP diameter and transverse diameter, and you will further check all the findings of inspection. Then, upon percussion, there will be hyperresonance in certain cases where there is a lot of air trapping. There might be hyperresonance on percussion. And then on auscultation, first you have to say about the breath sounds. Usually in the involved area, the vesicular breath sounds will be replaced by means breath sounds with expiration being prolonged. That means going towards the bronchial pattern. Apart from that, some abnormal or adventitious sounds such as crepitations, that to fine crepitations and bronchi will be auscultated. In severe conditions, because air entry will be very less, any type of breath sound, whether normal or adventitious, may not be able to be hearing because they will become inaudible in severe cases because of such a degree of obstruction that no air is able to enter itself. Okay, now we will get an x-ray. So what will be the findings on an x-ray? We will see hyperinflation, yes, and infiltrates. Yes, infiltrates will also be there. The diaphragm is pushed downwards, yes, and the lung fields appear abnormally translucent. Okay, that means air filled lung fields, they will be more dark, means more blackish on the x-ray. Hyperlucency will be there, hyperinflation will be there, some infiltrates will be seen. When we will do the blood count, the leukocyte will be normal or slightly elevated. And any specific test, so a rapid test on the nasopharyngeal aspirate can identify RSV. Nasopharyngeal aspirate, a rapid test for RSV diagnosis. Okay, now what is the cause and prognosis of the disease? Because this is the ultimate question that the patient asks you, that will I get well and how much time will it take for the recovery? So it's usually a self-limited illness. In 3 to 7 days the condition starts to improve, and in 1% of the cases there may be death because of respiratory failure. But one line here is important: the relationship of acute bronchiolitis to bronchial asthma in later life is seen in certain cases. Around 1/4 of the cases, means the children, when they have bronchiolitis in their childhood, many a times, means 1/4, means 25% of these cases in later life may develop bronchial asthma. So what are the differential diagnosis? They will ask you, okay, you are getting these findings on palpation, inspection and percussion and auscultation. So what are the various findings which are coming in your mind? The differential diagnosis. So you will say that first, okay, I'm thinking of acute bronchiolitis. Second option, it could be bronchial asthma. Number 3, heart failure. Number 4, foreign body. And number 5, bacterial pneumonia. Okay. So then they will tell you how can you differentiate if it's bronchiolitis or if it's asthma. So usually asthma does not occur in case of infants. That means most of the cases the patient of asthma will be a child who is more than 1 year of age. It's very rare to find asthma in a child or a baby who is less than 1 year of age. Whereas bronchiolitis, the most common age group is 1 to 6 months of age. So main first factor is the age at presentation. Number 2, asthma. In many cases there is a family history. Number three, asthma is a disease which has a lot of recurrences, remissions, all that going on, relapse, remission, exacerbation. So it's not that just once it occurs. It is episodic, it's full of exacerbations. There is a lot of past history you will elicit. That's point number three. And the fourth point in asthma, the clinical point, when we give any bronchodilator, asthma patients they respond much better as compared to patients of bronchiolitis upon giving bronchodilators. So the response to bronchodilators. So these are the 4 points of difference between bronchiolitis and bronchial asthma. The second you have said it is heart failure. So in heart failure again, why? Because in heart failure also you get the similar breath sounds may be there, fine crepitations will be there, there may be respiratory distress, there may be dyspnea. So in heart failure, what are the points of difference? You will see a cardiomegaly either on palpation. You can find when you delineate the borders of the heart, there you are seeing, or on a chest x-ray very easily you can make out cardiomegaly. Number two, there will be tachycardia, so pulse rate will also be affected, tachycardia. Then it's just CHF, so even there will be hepatomegaly, there will be an enlarged liver, raised JVP, and edema, pedal edema, and again fine crepes in the basal area, so basal crepitations. The third is foreign body. So in case of foreign body, number one most important is history. Okay. Number two, in foreign body there will be localized wheeze, and in the x-ray there will be signs of obstructive emphysema and collapse. And the fourth is pneumonia. So in case of pneumonia, the signs of obstruction are less pronounced. Means in pneumonia, airways are not obstructed, and it's not that air entry will be completely stopped, right? So these obstructive findings are not very much seen in pneumonia. Rather, you get other symptoms like fever is high, and adventitious sounds are very prominent to be seen in a patient with pneumonia. You get wheezing, you get sometimes stridor, you can very well appreciate the krebs, the rhonchi, all these adventitious sounds. Air entry is not inhibited, means too much of obstruction is usually never seen in pneumonia, but in bronchiolitis it may be seen in severe disease. So this is how you are going to differentiate it. Okay, so let's end this lecture there. In the coming lecture we'll continue with the treatment portion.